Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today. I'm a pediatrician in the Cincinnati area, and I'm very excited to be here for today's discussion on hypertension. I'd like to welcome Dr. Mark Mitsnefes with the Department of Nephrology at Cincinnati Children's. Today we will consult on hypertension with him. So welcome, Dr. Mitsnefes.
Thank you very much, Dr. Schaffeld.
Let's start by learning a little bit about you. If you could share just a few sentences about your background, maybe how long you've been practicing, specifically maybe even how long you've been practicing at Cincinnati Children's or any special interests you may have.
Sure. Yeah, I came to Cincinnati in 1997 for my fellowship. And after completing the fellowship in pediatric nephrology and hypertension, I was offered the position of faculty member. And at the same time, Division of Nephrology and Hypertension decided to join forces with Division of Cardiology and create hypertension clinic. And one of the cardiologists who was working on that was Dr. Steve Daniels, my mentor for my research. And it was natural for me to join hypertension clinic. So I've been working at Cincinnati Children's as a faculty member from 2000. And at the same time, I started being a hypertension doctor for basically, this is the beginning of hypertension clinic at Cincinnati Children's Hospital.
It's a lot of wonderful experience sitting in front of me, so we appreciate that. Any special interests beyond hypertension?
Yeah, so my research interest in cardiovascular risk factors in children with chronic kidney disease, and you understand that hypertension is one of those risk factors. But in addition, I also look at other cardiovascular risk factors like dyslipidemia, obesity, smoking. So basically traditional and CKD, chronic kidney disease-related risk factors. But the biggest part of my research related to hypertension.
Wonderful. I love listening to the kind of just integrated care that you've already mentioned multiple times, working with cardiology and working together in the hypertension clinic, that hypertension clinic itself doesn't just live in one division because it really does affect all those different systems.
Right. This is a very unique clinic. Actually, very few clinics, hypertension clinic around the country has joined forces of cardiology and nephrology. So I think Cincinnati Children's Hospital Medical Center is very fortunate to have this kind of combined program.
Absolutely. So today our conversation, as we've been mentioning, is on hypertension. Would you mind just sharing a kind of a quick overview of the condition and maybe any data off the top of your head on incidence or how often we as general pediatricians may encounter this in our practice?
Right. So hypertension is a silent disease, as you know, especially in children, because many children whom you guys seeing in your practice, basically they don't complain, right? They don't complain of headaches. They don't complain of any other hypertension-related symptoms. So the challenging is to find a child with elevated blood pressure, right? The overall incidence and the prevalence of hypertension is quite low. It's about 1.5%. Of course, that's nothing to compare with asthma or some acute illnesses that you're seeing, for example. But it's a very important topic, right? And I can tell you that typically I see every week about 5 to 7 new referral from primary pediatricians to my clinic. But I'm the only one, right, who's seeing 5-7, but there's other providers as well seeing a new referral. Sure. So this is relatively small prevalence, but we have quite significant referral base.
Is that 1.5% in general, is that defined as under 18, under what age range are we looking at for that percentage?
So for a child who is healthy and didn't have any chronic diseases after birth, as you know, the first time primary care provider will measure blood pressure when child is 3 years of age, right? So the statistics that I refer is between ages of 3 to 18. That's the pediatric ages, even though, of course, we see patients who are older than 18 and frequently up to 21 years of age.
Sure.
Right. But also 1.5% is just combined prevalence. And, of course, it depends on the risk factors as well. And what I'm referring to is obesity, because children with obesity, their prevalence is significantly higher and might reach, depending on the severity of obesity, up to 20%.
Wow.
For example, class 3 obesity, it's really, really the problem because hypertension could be up to 20%. And in class 1 obesity, it could be up to 10%. So you can see the significant difference between 1.5% in children who are not obese versus 10 times more for those who are severely obese.
Yeah, that's an interesting, thing as I listen to you talk about that, I think about, we measure blood pressures routinely, at least in my practice, at every well child check. If there's anything else that we're concerned about, they come in for a chief complaint of dizziness or headaches. Of course, we'll grab a blood pressure. But we don't always do it. And maybe that's something to think about, especially in children that might, be obese or children. Maybe it's something we should screen or take even a little more often than that once a year. It's an interesting thought.
Right. But I want to add something else because what we see over the last few years after pandemic and during pandemic, first of all, the prevalence of obesity is up. Prevalence of anxiety and depression is up. And I see the differences in prevalence of hypertension because we have many more referral for kids who are really, really struggling mentally.
Sure.
So obesity and mental problem, that's really the main base for referral from you, primary care physician, to my clinic.
Absolutely. Well, that highlighted a very important trend, I think, unfortunately, that we have seen over the past few years. And before we get into really talking about specifics with assessing blood pressure, can you speak a little towards just the long-term impact of hypertension and why, we know it's important and, thinking about it, I think this is maybe what makes it a little scary too, is because children don't have many of the outward signs, but yet we know that having hypertension for a long time can lead to other very serious complications.
Right, and actually I have to refer to two studies. One of them actually is from Cincinnati Children's Hospital Medical Center. The title is Ship Ahoy, and primary investigator is Dr. Elaine Urbina from Preventive Cardiology, and I've been fortunate to work with her on this project for many years now. And what this study showed that children with elevated blood pressure already have some preclinical symptoms of cardiovascular disease. What I'm talking about is asymptomatic diastolic function problem, asymptomatic systolic function. They might have also left ventricular hypertrophy, which is increased mass of the left ventricle, right? Wow. So we been tested this, and actually what is important, these problems start not with blood pressure above 95th percentile. That's how we define hypertension in young kids, right? But actually it started early when blood pressure mildly elevated. So I think it's also what I'm talking about, short-term problem related to hypertension, but there's also long-term problems. And that I have to refer to another paper that just was published a few months ago in New England Journal of Medicine. And this paper specifically looked at cardiovascular outcome in middle-aged adults who have cardiovascular risk factors during childhood. Wow. And they assess, in addition to hypertension, cholesterol level, triglyceride level, obesity, and smoking. And what they found that those patients who had mentioned cardiovascular risk factors during childhood, the prevalence of cardiovascular real outcomes, and I'm talking about myocardial infarction, stroke, was significantly higher than those who did not have this cardiovascular outcome. And each of those risk factors was associated independently with these outcomes, but if you combine them all together, the outcomes were even worse. So I think this study, really the first one, showed how important taking care of cardiovascular risk factors during childhood and be sure that they're not tracking to adulthood.
Sure. I think that's very impactful. We think all of us trained as physicians understand long-standing hypertension, cardiovascular risks, but to just have that direct correlation and that direct link to childhood hypertension, I think, is very impactful for us as pediatricians, and to realize how important, this just one vital sign we're taking can really be to, risk factors for the rest of their life. So,
right, and this is very important to really identify children with elevated blood pressure, and you're in the front seat for this, right? Because you see kids, and then you have to determine what to do with them, right, if they have elevated blood pressure.
Sure. And that is a perfect segue into what I'd like to talk about now, which is, as pediatricians, most of our patients, nurse or medical assistant brings them back. They take their vital signs. Can you share just a little bit about the proper way to take a blood pressure? Everything from, I think we all realize, proper cuff size is important, but are there specific things that we should be doing and we should be training our staff to do to make sure that we're getting a very accurate reading on that blood pressure?
Absolutely. This is such an important point. I can tell you that, unfortunately, many referrals could be avoided if primary care providers' practices really pay attention to how to measure blood pressure. Okay, so the first step, of course, to be sure that a child is in the room, in a quiet room, sitting at least for 5 minutes without interruption. Okay, and then frequently, we have a problem with a wrong blood pressure cuff size. And as you know, the best and gold standard to assess a cuff size is to measure arm circumference. That would be very important. I understand that primary care practices are very busy and probably don't have enough time to do it all the time, but these are the recommendations from clinical practice guidelines. Of course, so this is a very, very important part, especially if you're dealing with obese children. Frequently, primary care practices don't have thigh cuff that we use for very obese kids, right? And yes. Large adult cuff, maybe not big enough cuff. And this is actually one of the most common problem with artificially high blood pressure because wrong blood pressure cuff. So this is very important. But also very important is the position of a child, right? All normative values are for sitting blood pressure. So it's very important. The legs should be supported. Back should be supported. Arms should be on the level of the heart. And then, so this is all very small practical things that really affect blood pressure because blood pressure is very sensitive. Okay, and then you have to do one blood pressure measurement, wait for 30 seconds to 1 minute, and then take the second blood pressure on the same arm in the same position. And only after that you can make intelligent decision about what's really blood pressure is in this kid.
I'm getting a visual in my mind as you're telling, this is the position they should be in, and I'm thinking pretty much every patient that comes back to our office is in the wrong position. They're sitting on the side of the bed. Their feet are not on the ground. Their arms are definitely not at heart level, and their back's not supported because they're sitting on the side of the, bedside table or the bed that we examine them on. So all of those things are not correct, but very important, when we do get that elevated reading to say, you know what, let's do these things, give it a few minutes, and take that second reading, right?
Right.
So,
But I also think that if you found elevated blood pressure, you also have to think, oh, what kind of equipment did I use?
Sure.
Was it manual equipment or it was a telemetric device, digital device, right? The recommendations are very clear. If the first measurement was done by a telemetric device and it's elevated, then you have to repeat it manually, right? However, some practices might have problem having manual equipment. So there is some recommendation what to do if the first reading with a telemetric device elevated. Actually, the recommendations are very clear. You have to do second measurement and then third measurement and then get away from the first measurement and calculate average of the second and third measurements with a telemetric device if there is a problem with manual equipment.
Oh, interesting. Okay. I had no idea. I do remember, it's funny thinking back even into my residency here at Cincinnati Children's, and whenever I would get that page, so-and-so's blood pressure is high, the first thing I would say is, was that a manual cuff or an automatic? Can you please take it manually? So I didn't realize, though, if you don't have the equipment to do such, that you should take the average, which I guess does make sense.
Yeah, the first measurement with digital device frequently overestimates the real blood pressure.
Sure.
So that's why the recommendation repeated second time and ideally the third time.
Great. Is there any use, since we're talking about specific ways to take a blood pressure? Obviously, I think we all as general pediatricians are going to know the big, as I start to say this, who this would be most concerned and what age group. But any use as beyond infancy for 4 extremity blood pressures?
Oh, that is an interesting question. There was a paper published, I think last year in Journal of Pediatrics looking at adherence to clinical practice guidelines on measurement of blood pressure, right? And apparently not every, and that was a study of more than 50 primary care practices. And the adherence to measurement upper and lower extremities was really very low, very low. But definitely you need to do that, especially if the first blood pressure is elevated or average blood pressure in the upper extremities is elevated, right? Okay. You have to do that, especially if it's stage 2 hypertension. However, if there is a problem with equipment, because if you deal with overweight kids, even a thigh cuff sometimes would be not large enough.
Wow.
So really, really important to measure femoral pulses, okay? So this really kind of substitution for measurement of lower extremities blood pressure, yes.
And you mentioned stage 2 hypertension. Can you discuss a little bit about what constitutes stage 1 versus stage 2?
Right. So a clinical practice guidelines been published in 2017 in September in Pediatrics. By the way, this is excellent source for any providers, including general pediatrician and subspecialist, to look and learn about management of hypertension in children. So first of all, it's divided in 2 age groups, less than 13 and 13 and older. And I will just right away say that for those who are older, 13 and older, the cutoff points for normal, elevated, and hypertension are the same as for adults. And of course, for younger kids, we are based the classification based on the percentiles. So elevated blood pressure is between 90 and 95th percentile. Stage 1 hypertension between 95th percentile plus 12 millimeter, 12 points, and stage 2 above 12 points. And for 13 and older, normal blood pressure below 120/80. Elevated blood pressure is between 120 to 130/80. Stage 1 is 130 to 140/80 to 90, and stage 2 hypertension above 140/90. So that's a classification that we are working. And interestingly enough, that this new classification showed, comparing to previous one that was in 2004, actually it better correlate with target organ damage that I mentioned before, like left ventricular hypertrophy, for example.
Yeah. So if in the office, I see a patient that, say, at this point, just blood pressure's taken. I do everything I should in terms of making sure it's a manual pressure, blood pressure that's taking, making sure the cuff size is okay, the child is in the correct position. So all of those factors check out all right, but that blood pressure remains in that stage 1. When is the best time, or how long should I follow that up? Is that something that you say, see back in 4 weeks, see back in 6 weeks, and how many of those measurements do I need in, say, a stage 1 or a stage 2 range to truly say, okay, this is definitely hypertension, this is definitely a problem?
Right. When you confirm that child has elevated blood pressure or stage 1 and stage 2, there's specific guidance on the follow-up that you can find in clinical practice guidelines. But just to summarize, for those who have mildly elevated blood pressure, not hypertension, but mildly elevated, the guidelines would say bring them back within 6 months, after 6 months of follow-up. For those who have stage 1 hypertension, ideally you have to bring them within first months and repeat it. I typically would recommend, to bring them within 2 weeks, and then, by the way, to really diagnose patient with hypertension, you need 3 separate visits, right? Mm-hmm. So if you see them on the first visit and high blood pressure, bring them second, and then bring them for the third time. And if during all these 3 visits blood pressure is elevated, here it is. You diagnose them with hypertension. For stage 2 hypertension, you have to be more aggressive, right, in the follow-up. Definitely, you can refer patient right away to subspecialist or bring them within first week, and you have also to do some screening to find the secondary hypertension. And we can talk about, the second, what ideally, right, why the follow-up is different for those who have suspected secondary hypertension versus primary hypertension.
I think this is a perfect time to talk about that. So what workup is appropriate in that situation? What, lab work do you typically recommend as your initial lab work for hypertension? And then even if you want to speak a little bit towards at what point is a renal ultrasound appropriate in diagnosis?
Right. So when child is referred to my clinic, even before we see this patient, we already order some screening tests, right? Of course, ideally, if you feel comfortable as a primary pediatrician, you can definitely do it in your practice. But typically, we check kidney function. We look at TSH to be sure that there is no problem with thyroid, right? We also look at urine analysis, right? And because most of the kids that are referred have obesity, we also look not just on factors that might be associated with hypertension, but we also look at some other cardiovascular risk factors. Typically, we check lipid profile to know their cholesterol. We check also hemoglobin A1C to be sure that they don't have risk for diabetes, as well as liver enzymes, because many of these kids might have fatty liver. So that's a screening test that recommended by practical guidelines as well. That what we utilize in our clinic here in Cincinnati. As far as kidney ultrasound, it's actually excellent question, because you remember I referred you to Journal of Pediatrics on adherence to guidelines. And the current recommendation to do kidney ultrasound if there is a confirmed stage 1 hypertension. Honestly, I don't agree with these guidelines. And the adherence, by the way, on this paper that I refer was almost zero, because primary care physicians don't do that. And I think it's appropriate not to do that. Why? Because majority of these patients have some other risk factors, right? By physical exam and by history, you probably will eliminate kidney disease in majority of cases, 80%. So, doing kidney ultrasound you really have a good suspicion for kidney disease. Okay, so while recommendations are recommendations, guidelines are guidelines. It's not 100% you have to follow.
Sure.
So if you're concerned about kidney disease, sure, you can order. But in majority of cases, I would probably skip it.
I love to hear that because I'm thinking that in my 13 plus years, I don't think I've ever ordered a renal ultrasound on a child that had hypertension in my office, so that makes me feel a little bit better.
Yeah, that's confirmed. That's confirmed my notion as well.
Well, good. But it does make sense, as you said, and I think it is a very good point. If you are proceeding as a general pediatrician with some of those general screening labs before referral, and maybe there is a bump in the creatinine or there is something to indicate in the history that there may be something with kidney disease, or there's an excess of protein in the urine, something else that maybe triggers you to be a little more suspicious, that it is appropriate in that case, but in many cases, it's not.
Yeah, I just want to clarify something that I'm referring to mild hypertension. Of course, if you have a child without any other risk factors, for example, no obesity, right, and the child is lean but have stage 2 hypertension, you might order kidney ultrasound even without sending kids to subspecialists, because we do that. If I can find any risk factors, for primary hypertension, I have to assess secondary hypertension, right? And
Sure.
The most important cause of secondary hypertension is kidney disease. So kidney ultrasounds is right there.
Absolutely. One of the things that if we did not practice at Cincinnati Children's, or as a general pediatrician, if I did not have Cincinnati Children's so close, because we do have a variety of listeners, I'm trying to just think of everyone out there if they maybe are not in the general Cincinnati area, and they don't have the luxury of a hypertension clinic that is multidisciplinary with cardiology and nephrology. Are there any tips or tricks that you can give those pediatricians on when hypertension should be referred to cardiology versus when to nephrology? And that's very hard because I feel like that's really splitting hairs asking you that question. But is there any patients that you can think just clear-cut should go to one specialty versus the other?
Right. Of course, if you have child with heart palpitations or cardiac murmur or some arrhythmias and hypertension, clearly you have to refer this to cardiologist, right? But the rest can go to both, right? Nephrology and cardiology. We see them all. But also, at least from experience from Cincinnati Children's Hypertension Clinic, we decided that nephrology will see all kids with age less than 7. And the reason for this is because they're most likely to have secondary hypertension. Okay, and secondary hypertension, of course, I'm not talking about coarctation of the aorta or all symptoms that I described before.
Sure.
It's mostly related not to heart problems. So that's why the decision was for young kids, nephrology will take care of this. So that's probably good for primary care physicians as well, follow the same pattern.
I absolutely didn't know that, so I think that was great information to share. I guess I'm thankful as I ask this question that this is not something that I see often, but any need, or I guess what criteria would or should push a general pediatrician to refer a patient to the emergency room? I'd say it's pretty few and far between that we would ever need to do that, which is wonderful.
Yeah, I think we are talking about red flags, basically, right? And severe headache with hypertension, blurred vision, absolutely, you have to refer it. Heart palpitation that you think that there is going to be very difficult to control, you have to refer them probably to emergency room. While we are talking about stage 2 hypertension, you have to be careful to send them all. You don't need to send every patient with stage 2 hypertension to emergency room. However, if child has so-called urgent hypertension or emergent hypertension, right, you might have send them right away. And what I'm talking, right now, at least the definition of urgent hypertension is you take stage 1 hypertension plus 30 millimeters above. So that's quite higher than 12 millimeters when you define stage 2 hypertension, right?
Sure.
So if you have really, really very high number for blood pressure, even child might be not symptomatic, but I think you might send this kid to emergency room as well, just for screening evaluation, because it may be done much faster than in primary care office.
And my thought on that is maybe even at least reach out to the specialist too, because I do feel like we are blessed and lucky that Cincinnati Children's is in our backyard, but oftentimes, when we reach out to the specialists, it's, we'll see them today. We'll see them in the next 24 hours, which is wonderful.
Yeah.
But I think that's a great point. I had never heard that classification of emergent or urgent hypertension being 30 millimeters above. So
Right.
it's good
Right.
to know.
And I think, we're 24/7 on call. You can use Priority Link, of course, and one of the, typically it's a nephrology provider will answer your questions. And, if you're not certain, of course, just give us a call and we will make decision together.
Great. I appreciate that. So heading into the assessment a little bit more, which I know we touched on before, you had mentioned femoral readings, femoral pulses, and kind of assessing that. Can you share a little bit more about that?
Yeah. So this is really very rare condition. We're talking about why we're doing femoral pulses, right? Because we want to rule out coarctation of the aorta. Yes, I understand that this is a very rare disease. However, unfortunately, few cases per year we are receiving. For example, recently I saw a 17-year-old boy who was referred by a pediatrician for high blood pressure, right? And unfortunately, lower blood pressure extremities wasn't measured in this particular case, right? So when we see that patients, and in nephrology, in hypertension clinic, actually, when we see patient for the first time, we measure blood pressure in upper and lower extremities because we already assume the child has high blood pressure. That was determined during primary care visits, right? And one of my nurses just came back from the room and said, I can't find lower extremities blood pressure.
Wow.
And when you see that, right, I said to my nurse, by the way, I'm talking about Debbie Parrott, who's been with me for the last 20 years. And, she's such an expert in
That's what I was thinking. Someone who does this all the time.
Exactly. So we have a good group of trained nurses. And she said basically, well, I can't hear, no lower extremities blood pressure at all. I mean, she already made a diagnosis, right? So my goal was to come to the room, listen carefully to the heart, and I see classical heart sounds, right? When you see the murmur that you can refer to the back, and the next step was to call cardiology, right? We're fortunate because our clinic on the same floor, it's a C4, which is a cardiology floor.
Sure.
So right away, this kid had echocardiography and was diagnosed with quite severe coarctation of the aorta. So I just want to emphasize one more time that really, really good history and physical exam, including femoral pulses, if you are not able to measure blood pressure in the lower extremities, very, very important because it really can affect child life. We can wait for 17 years. It's probably not a good way to do it. This child probably could be diagnosed when he was at least 3 years of age, right,
Sure.
with this disease. So this is kind of a negative example, but I also have some good positive examples, right, when we talk about not just assessment, but management, but we can,
Sure.
discuss it later.
I think that's a great example. We all, as general pediatricians, learn the pediatric exam from infancy, but I'll be honest, I can't tell you how many times I check femoral pulses, once they get out of infancy stage. And to just realize and remember how important that may be in the diagnosis, think is a great reminder.
Right. And just keep in mind that you need to do it in the case if blood pressure is high on the upper extremities, right? If blood
Sure.
pressure is normal, you probably don't need to do that.
Yes, absolutely. And now, if you would like to, we can discuss a little bit about management. I think a lot of this from a general pediatric standpoint is after the referral takes place. But I think it's good for us to know some basic management and when that would come into play. And when do you look at treating and what do you first treat with? Because some of these, even if they do start seeing you, they will be still visiting us, and we should know what medicines they're on. Are there any side effects we need to watch for? That sort of thing.
Right.
As well as lifestyle changes.
So management seems to be simple, right? You start with lifestyle modification with those kids who have stage 1 hypertension or elevated blood pressure. It sounds simple, right? And a lifestyle modification, I'm sure that every primary care practice will talk about it, right? Including diet and exercises. And in the hypertension clinic, we have actually 2 dietitians who will have appointment with patients and discuss everything. And we also have exercise physiologists if we need to talk about exercise and what could be done for these particular patients. It sounds easy, but you probably can ask the question, how successful are you in your practice with lifestyle modification, right?
Sure.
And I will be very honest, only 10 to 15% after all vigorous conversation about what needs to be done will have a success. And that brings me to, my recent case. I see a patient who was actually admitted to the hospital with very high blood pressure, like 180 over 100, and was started on blood pressure medication. Very severely obese child. Probably his blood pressure was triggered by migraine, which also frequently happened in children who are obese, right? And then I see this patient after discharge of the hospital, and we discuss what needs to be done, right? Yes, he's on blood pressure medication, on ACE inhibitor, but that's not the point what I want to emphasize. Simple discussion, and I see him in 1 month after the first appointment, he already lost 10 pounds.
Wow.
And now, after 6 months of follow-up, he came and he lost total over 70 pounds.
Wow.
Right? And now his blood pressure is completely normal. So I'm just saying, hey, you're probably going to stop this medication very soon. Let's wait for another 6 months and let's see what happens. But so there's some successes.
Wonderful success
there's
story.
some
I love
successes,
that.
unfortunately, not frequently.
Yeah,
Unfortunately, not
definitely.
frequently.
Well, that was wonderful, and I think great information for pediatricians to share.
And by the way, you understand, this is just an example that showed that this intervention works if you follow it, right?
Absolutely.
And the recommendation for diet, if we want to discuss it a little bit further, definitely for many kids, we prefer DASH diet, which stands for Dietary Approach to Stop Hypertension, right? But I'll just come back to this case, right? I said, Tell me, why do you think that you're so successful in weight loss? His only single answer was portion control.
Wow.
Portion control. So this is probably the most important. Okay, we can talk about, oh yes, you have whole bread versus, oh, you have more vegetables or more fruit. But if you don't have portion control, probably the success would be minimal.
That makes perfect sense. You mentioned the DASH diet, which I'm not super familiar with. Is there a resource that you can direct us towards?
Yes,
learn
absolutely.
More about
Actually,
the
if
DASH
you
diet?
just type DASH diet, it's right there. But to summarize, this is a balanced diet. This is not starving diet, of course, but it includes many portions of fruits and vegetables, low salt, high potassium, and high fibers. So that's the diet, right? If you need some information, that should be on website, and definitely you can always call to hypertension clinic, and we would be happy to provide with handouts on DASH diet and other dietary information, for example, related to low salt, right, diet.
Yeah, absolutely. Well, that is perfect. If there's anything else you would like to share with us, but your expertise has been wonderful, and I think that general pediatricians will very much appreciate this.
Yeah, so frequently I ask my general pediatrician, can I start blood pressure medications? And when do I need to start blood pressure medications, right? And I said, if you feel comfortable, please do, right? It's the recommendation for first line of antihypertensive medication. There are 3 classes of medication. One is ACE inhibitors and ARBs, right? And you don't need to use or to choose between many of them. Just choose medication that you're really comfortable with. In my clinic, I typically use for younger kids enalapril, and for older kids lisinopril. And as far as ARBs, it's losartan, right? The second class is long-acting calcium channel blockers, and there's also amlodipine is a very good medication, right? And the third class of the first-line therapy is thiazide diuretic, hydrochlorothiazide. That's a medication that we frequently use. I also want to emphasize that frequently one medication might not work. So there is a definitely combination of pills, which is preferable. It's one pill with 2 drugs. It can be ACE and hydrochlorothiazide, and it could be calcium channel blocker and diuretics, right? So that's also we frequently utilize this combination to treat kids. But again, that's the 3 classes of antihypertensive medication. So if you feel comfortable, please do. Lately, because of a very significant prevalence of anxiety, and kids come with heart palpitations, for example, and increased heart rate, I think one of the reasons for them to have high blood pressure is a lot of stress. A lot of stress will lead to increased sympathetic activity, which will increase to heart rate. And that's why I recently started using more beta blockers, even though beta blockers are not the first-line therapy, but kids respond very well. It's a very good blood pressure medication. You always have to balance between benefits and side effects, right?
So for that subset of patients, it makes perfect sense with the anxiety on top of it.
Exactly. Yeah. So, and you can use different beta blockers, right? I prefer right now metoprolol, and it can come as a short-acting or long-acting. For example, if I see a kid who has high heart rate during the daytime, but he sleeps and his blood pressure is good. By the way, we haven't talked about ambulatory blood pressure monitoring, which is really, really one of the very important part of my assessment in hypertension clinic. But what I'm saying, if blood pressure at night is normal and he only has high blood pressure during the day, I use short-acting beta blocker, for example, right?
Yes, definitely. Thank you for sharing that. That's another... I'm used to not managing with starting medications, but there might be many pediatricians out there that are listening that don't have the luxury of having a hypertension clinic to refer to, and that's wonderful information, I think, to share for them as well.
Yeah, and just a few words about ambulatory blood pressure monitoring, because now actually you can order it on Epic. If you are a provider related to Cincinnati Children's Hospital, and one of our nurses, either in nephrology or in cardiology, will contact primary care physician, and we will schedule patient for our dedicated ABPM clinic that run by nephrology group.
Great. That's wonderful. Thank you. Well, I guess we will wrap up. I appreciate all your time today and all your expertise, and it was very enjoyable chatting with you and you sharing all your knowledge with us. So thank you so much.
Thank you for inviting.
And I just also wanted to share a mention that CME credit will be available and will be linked on the bottom of the podcast page, as well as many of the studies we referenced here, information on the DASH diet and the clinical guidelines that were referenced.